What is the role of umbilical cord-derived stem cells in the effective treatment of Alzheimer's?
So,
Effective, yes or no?
Umbilical cord stem cells are very much in the early development. Stem cells have been theorized. The problem with stem cell research in Alzheimer's is that Alzheimer's is a widely distributed disease in the brain, so it's not like Parkinson where you can target a specific spot in the brain and say this is where the stem cells go. There has been some gene therapy which is getting a lot of traction, but stem cell is not as in the center of the conversation as you would think.
How many years away before we know? Best guess.
For stem cell therapy?
Yeah.
Probably 10.
Yeah. I would say even that's probably optimistic. We have somebody asking us to clarify, what is the effect of memantine or donepezil if started in patients with mild cognitive impairment? What would you say?
Well, I would say that memantine has been looked at and doesn't have a lick of benefit in mild cognitive impairment, so I routinely do not use memantine. The data is soft on donepezil as well. It has one study that's positive, but it did not meet its endpoint. It is not approved.
Approved by the FDA.
Approved by the FDA.
For treatment of
mild cognitive impairment. I will say to you, if I have to choose, I might choose donepezil because it has a little bit of data, although it is not approved. And I tell them the family up front, that it's not approved. This is not approved treatment.
So let's dwell on this for a minute, because this is, I think, a clinical space we'll all be grappling with a lot more in the years to come. There are probably at least 8 to 10 million U.S. residents with mild cognitive impairment, so this is a big deal. What I do is tell people there's no FDA-approved treatment. I tell them, just as you said, that the studies of memantine in very mild disease show inconsistent and non-robust benefit, not approved. That the studies with cholinesterase inhibitors net are inconclusive, but there's evidence that maybe some individuals might benefit in terms of slowed progression of symptoms. And we have that kind of off-label conversation.
Right. I would say that's true, but even to get to that conversation, I would make sure I'm dealing with the prodromal Alzheimer's mild cognitive impairment state and not the non-prodromal. So the non-amnestic forms, I'm looking for other causes, sleep apnea, depression, polypharmacy. So this is really kind of couched toward the amnestic forms.
Okay. Marwan, this is right up your alley, so I'll start with the answer, but then turn it over to you. What about, we've focused on medication approaches to treatment and maybe even, quote, prevention, but what about non-medication approaches? You're the expert. Here's what I would say. I think they're incredibly important in two ways. If you have symptoms already, it is very likely that social stimulation, aerobic exercise, a healthy diet, the right kind of intellectual stimulation will probably help your noggin work better. And for those of us at risk for Alzheimer's disease because we're advancing in age, midlife lifestyle changes may have the potential to reduce risk by as much, other experts say, as much as 50%. What would you say?
I would agree. I would tell you that there's now good data, not soft data, that's suggesting that engaging in activities like healthy diet, lower saturated fat, Mediterranean diet, things like that, reduce the risk of cognitive decline and reduce cognitive decline itself. We also know that engaging in activities like physical exercise and mentally stimulating activities have a positive benefit. The only problem with some of that science, the physical exercise, the science is good on it, defining how much benefit. The social stimulation, the Sudokus, word games, crossword puzzles, etc., they are a little bit on soft on the intensity effect and dose effects. We know that people who do them do better, but we don't know how much, how long, how often, etc. So that a lot of things still unanswered, but conceptually they all have data to support the use of it.
Okay. I'm going to paint you into the corner. Wine, yes or no, and if yes, red or white?
So if you believe the Nurses' Health Study, they say any alcohol consumption less than 30 grams have an 8 to 12% reduction, if you believe any. If you believe the French paradox, it is red wine because it has resveratrol. But truth be told, Pierre, you cannot drink that much resveratrol in a glass of red wine. So I think wine has some benefits related to the antioxidant effects, and I think red wine, but there's no absolute data to support that beyond a feel-good option.
So you tell people what?
I tell people to be careful about their alcohol consumption to less than 30 grams a day, 2 beverages a day. Because we know that above 30 grams, your cognitive decline goes up, not down. So I'm very careful about saying that. And then I say, red wine consumption makes sense, but the data is not absolutely favoring that over other beverages.
And you use grams, I would say 2 4-ounce servings for those of you who care about your own brain hygiene or your patients. Marwan, say a little more about, we have a question about routine laboratory testing. So just march through one more time what you would do in a kind of routine case, and then we'll maybe talk about atypical cases.
I will say to you, I ordered a lot of B12s, TSH, folic acid. Sometimes I add an MMA, methylmalonic acid. Sometimes I add a homocysteine. Fact is, Pierre, I've treated a lot of thyroids and a lot of B12s, and they all end up still having Alzheimer's disease. I don't think we have true B12 deficiency or true hypothyroidism causing as much dementia as we would like. Similarly, on an MRI, we see everybody has a little bit of chronic paraventricular ischemic white matter change. That's not vascular dementia, and we think that they have vascular dementia. And again, we give them antiplatelet therapy, and we think they're going to get better, and they don't. So the bottom line is the standard approach normalizes a lot of things if there's any deficiencies, but doesn't treat the underlying Alzheimer's.
Yeah. Let's linger there for a minute. It turns out that there's fairly compelling literature about what happens to a person with dementia in a kind of general medical setting. Often the dementia is not recognized at all.
Agreed.
During the person's life.
Agreed.
Or at least labeled. Even if it is, it's not labeled until the person has fairly advanced symptoms on average.
Agreed.
Even if it's labeled as a dementia, which is not a diagnosis, as you know, but I want to emphasize that for our primary care colleagues, the dementia isn't diagnosed specifically.
That's correct.
I think we need to kind of make the diagnostic, differential diagnostic process less mysterious for our primary care colleagues. There's a pretty typical story for Alzheimer's disease.
Absolutely.
Late life, insidious onset, relentless progression, routine workup is negative. That's probably Alzheimer's.
About 70% of the time it is.
Yeah. If somebody in primary care is going to do the workup, there tends to be over-reliance on labs and imaging reports. And so if I were to order an MRI and I get it back and it says non-specific white matter changes consistent with microvascular disease, you would say,
that's an age-associated finding. Everybody over the age of 70 has it, and I wouldn't get excited about it.
Right. And as we know from our expert colleagues in pathology, if you look at that brain tissue under the microscope, you don't see microvascular disease.
Correct, that's correct.
Unless there's massive white matter change on MRI, like more than 25% confluent areas. Instead, you see something called rarefaction. So what I'm being too convoluted about it. White matter changes don't equal vascular disease.
Right. To be very clear on this, there's a threshold. So a lot of people, most people actually have a little bit of white matter change.
Right.
But you have to get to a threshold of 50 cc's of white matter rarefaction. That's would be rated as moderate or severe for you to kind of pay attention and say, that vascular change is contributing to their cognitive decline. Anything in the mild state, mild is not.
Okay, so imagine you are training 1,000 primary care docs on how to become dementia capable. You've outlined your approach to diagnostic workup. Out of the first 100 that I see, pretend I'm your audience or a member of your audience, out of the first 100 patients with dementia I see, what's the breakdown in diagnoses?
Well, what we would know is that in an accurate setting, we're not that good. We can only make a diagnosis without use of technology 70 to 75% of the time. So, first thing I would say is how is the history? What's the exam? I would order different tests in the modern era. I might but this is me, Pierre, speaking as a specialist. You know,
That's okay. We'll allow it.
Okay, I love the use of things like neuropsych testing. I love the use of PETs if I can get them paid for. So I think we can be better than guessing. I tell you what I've seen a lot of primary care physicians doing, because now things like Aricept and donepezil, or I should say donepezil, are cheap, is that they'll just give it and see if they get better, kind of like we used to do with Sinemet and Tremor. I think that, you know, relying on B12s, TSHs, and MRIs only does not give us as much comfort or reassurance as we'd like to have.
Right.
So primary care physicians are really wanting to have an ability with confidence, and so they're reluctant because they don't have that confidence.
Yeah. So we're in I would say we've got this interesting paradox right now. We clinicians, we can do a pretty good job with a clinical assessment. And my answer to this person's question would be, you know, with somebody with a slowly progressive dementia later in life, when we do our evaluation, maybe 70%, as you said, of the time that's going to be primarily Alzheimer's disease as the culprit. Relatively infrequently will it be pure vascular dementia. You've got to have a full-blown clinical picture to justify that diagnosis. Sometimes you've got both, and that's tricky. Maybe 15% or so the dementia with Parkinsonian features that we didn't get into too much, but just hint that that's tricky because Alzheimer's patients can have Parkinsonian features. There's Lewy body disease, there's Parkinson's disease, and then there's the relatively smaller group of the other dementias, such as the frontotemporal dementias. So if you think about those four categories, you can do a reasonable job clinically. And then at the same time, you know, there's this explosion in biomarker data that will probably allow us in the very near to intermediate future to be much more specific in our pathological diagnoses.
And to, you know, Pierre, those four categories, that's over 90% of all the dementias, period.
So say again.
Those four
Yes,
categories of dementia that you mentioned constitutes over 90% of the entire, category of dementia.
Do you test for vitamin D?
I don't.
Why not?
I know there's some evidence that vitamin D deficiency causes cognitive decline, and I just haven't seen it routinely done. I don't know. Do you?
It's a moving target.
It's a moving target. Yeah, put it that
I'm
way.
following the lead of our primary care and internal medicine experts. We're running out of time. Vitamin E, yes or no?
Well, the used to be no. Last year was no. Now the pendulum swung back to yes in combination with memantine in moderate. So 2,000, but it's only in certain categories.
Okay.